First, next slide. Next. Okay. Now we are all familiar with the WHO analgesic ladder, in which we said that there is a 3-step ladder starting from non-opioids with adjuvant to mild opioid with adjuvant or a non-opioid. And the third step would be the strong opioids with non-opioid and with or without an adjuvant. Next, please. Next. But with using the 3-step ladder, we are able to treat only 71 to 76% of patients. Okay, and there is a small segment of patients, around 10 to 15% of patients, who have refractory pain or what we call difficult to treat pain. Next, please. So what is a definition? It can also be called intractable pain, persistent pain, or opioid non-responsive pain. And it is defined as pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. Next. So there are some risk factors for a person to have intractable pain. What are the risk factors? Patients who are young are more prone to have difficult to treat pain. Those with neuropathic pains are also very difficult to treat. Incident pain can be difficult to treat. When there's psychological distress, the pain may not be amenable to your regular analgesics. Or if there's a history of previous opioid use, or if the patient is tolerant to opioids, history of addiction, and impaired cognition. So these are some of the risk factors for difficult pain. Now let me start off with a case scenario of how I encountered a patient with difficult pain. This was a 62-year-old man with CA rectum who had peritoneal and liver metastasis, and he was on chemotherapy for the last 1 year. He had developed acute intestinal obstruction with pain abdomen due to progression of the primary lesion. So he was taken to the emergency room and admitted for conservative management of intestinal obstruction. At this stage, he had become very weak and emaciated as well. So there they inserted a Ryle's tube and did a colostomy for him. And he was discharged with the advice of continuing with palliative care. Next. Now, initially, this gentleman was taking step 1 and 2 drugs through the nasogastric tube, because when he was discharged, he had the nasogastric tube and along with adjuvants for his pain abdomen. But the abdominal pain persisted, and then he had to be started on oral step 3 drugs, that is strong opioids like morphine. But one fine day, he pulled out his Ryle's tube, and he had categorically mentioned that I do not want this inserted again. He was very averse to the Ryle's tube. So there was a family discussion as to how to feed him and how to give him the oral medications. Because by this time he was emaciated and very weak. But because that was the patient wish that he did not want a Ryle's tube inserted, and we decided that we will respect his wishes. Okay, it was very easy to put in a Ryle's tube for him because he was so weak. He would not have resisted it, but because that was his wish, we respected patient autonomy and we decided not to reinsert the tube, and we will do other means for his management. So he was started, the chemo port was there, and he was started on IV fluids like maintenance fluids. And most of his medications were then given through the IV. But the pain grew worse, and then we had to put him on a transdermal fentanyl patch, 25 microgram per hour, but he had so much of pain, incident pain, that he was even given this oral lollipops, that is the oral transmucosal fentanyl citrate, OTFC, lollipops of fentanyl, which contains 200 mics of fentanyl, that had to be given SOS. Despite this, he had no relief, and he was in agonizing pain. He was even shouting in pain. The family was extremely distressed. And what do we do for this patient? Okay, now next, please. So what are the steps to treat difficult pain? The first and foremost step is to review the whole case scenario and see what can be done for this patient. And after that, we need to manage the pain either by pharmacological methods or by non-pharmacological therapy. So this is a broad outline how to treat difficult pain. Next, the pharmacological methods would be either root conversion or root rotation or add adjuvants to it. And the non-pharmacological methods of treatment of this kind of patient would be either interventional pain management, psychological therapies, physical therapy, alternate therapy, and spiritual therapy. Okay, next, please. Now, when we look at when we review the patient, it's useful to remember A, B, C. A is the patient adhering to the treatment that you're giving? B stands for believe the patient. It was Margot McCaffrey in 1968 who said that pain is whatever the experiences patient says is existing whenever he or she does. In simple terms, pain is what the patient says hurts. Now C, go back please, go back. C stands for a comprehensive pain assessment. So in a comprehensive, we have to once again assess the patient. Okay, and in that we look at the pain characteristics, which you're all aware of, PQRSTU. We look at the functional history. We review the prior drug and non-drug history. Then we do an examination of the patient, and then again we review the patient. And then another C is to correct the correctable factors. This could be whether if there's an effusion, the pleural effusion, we need to tap it, or we need to treat an underlying infection. If there's insomnia, anxiety, or nutritional status, all need to be corrected. Next, please. Now, adherence to treatment. In this, we have to review his analgesic regime, review the adjuvants that he's taking, check whether the patient has understood the dose regime, and use teach-back techniques. So if the prescription writes paracetamol 500 mg TID, morphine 10 mg Q4H with SOS doses, and bisoprolol and lorazepam and gabapentin, you ask the patient to tell back, or the caregiver to tell back all this to make sure that they are taking according to what you have written. That is called teach-back techniques. Because if the patient hasn't understood it, they may not be taking as per what you have advised. So it is always wise to see whether they're adhering to the treatment in the first place. Next, please. So what are the reasons for opioid ineffectiveness? The most common reason for difficult to treat pain is accumulation of toxic metabolites. I will talk about it in the next slide. Then, whether the disease has progressed, that is a very common cause for non-responsive pain. Or is there a new pain type? Has he, in addition, developed a neuropathic pain, or is there a bowel obstruction, or is there a spasticity? Then you may have to add some adjuvants for that. And then there could be intolerable side effects with what the present regime. This could be neurotoxicity, which could manifest as sedation, delirium, hyperalgesia, or myoclonus. Or is there a failed route of administration? The route that you're giving, for example, if I was giving the patient orally, is there poor oral absorption? Or if you're giving a transdermal fentanyl patch, is there a poor transdermal skin absorption? Or if you're giving a patient-controlled analgesia or an epidural and it's not working, you have to look for a malfunction. Is it a catheter malfunction, or is the pump not working? Is the needle blocked? Is the catheter misplaced? There are so many reasons why it is not working. So you have to see whether the route of administration you're giving is working in this patient or not. And then, most important, you must look at the physical, psychological, social, and spiritual factors. So now let us look at the pharmacological management of difficult pain. Next, please. So what are the options for pharmacological management? First is opioid manipulation. Now, opioid manipulation is the patient is taking a strong opioid, it is not effective. So do we have to convert the route, say from oral to parenteral or oral to transdermal, or do we need to do an opioid rotation or what is called an opioid switch? Okay, that is called opioid manipulation. Then we have to see whether an adjuvant has to be added. That depends upon the type of pain or whether there's a new onset kind of pain, which is maybe like in this patient, he had severe abdominal pain. Okay, so we have to add accordingly one of the adjuvants. Next, please. So sometimes in difficult pain, you may have to resort to intravenous opioids and not oral opioids. Okay, now this can be given for continuous pain. You can give continuous infusion. Okay, like a syringe pump, you can use a continuous infusion. But if there is an incident pain, then you can give even an intermittent bolus. But if there's both continuous and incident pain, then we can give what is called a patient-controlled analgesia or a PCA pump. These PCA pumps will allow the patient to self-administer the parenteral opioids. So it is given as a continuous basal infusion, depending on the degree of pain the patient is having. And then for the breakthrough pain, the patient himself can give a bolus, because there are two kinds of pumps. One is the disposable elastomeric pump, in which here also you have a remote, or you have the CADD pump, which is called the continuous ambulatory drug delivery pump. This also has a remote. Okay. So either way, it's called a patient-controlled analgesia. So that is given for patient who has continuous pain with intermittent incident pain, which is quite severe. Next, please. So parenteral opioids, like I said, is like a route conversion. You're giving the same opioid, but in a different route of administration. For example, oral morphine is converted to IV morphine, or a transdermal fentanyl is converted to an intravenous fentanyl. So high serum concentrations of opioid can be achieved by either the intravenous or the subcutaneous route as well. And both morphine and fentanyl can be given through both these routes, intravenous and subcutaneous. There is a conversion factor to convert oral to subcutaneous or IV morphine, which is 3:2:1. That means 30 mg oral morphine is equivalent to 20 mg of subcutaneous and 10 mg of IV. So that is a good rule to remember when you're wanting to convert the route of morphine. Next, please. Now, there is no evidence of the superiority of the parenteral route versus the oral route to control intractable cancer pain. Yet, the European Association of Palliative Care does recommend the use of parenteral opioid infusions in cases where oral or transdermal opioids are ineffective to treat the difficult pain. So you can use one of these routes. Or next, please. Now the other, yeah.
Sorry, we lost you for a few seconds in between. Now
Okay.
we can hear. Now we can hear.
Now, opioid rotation, that is the other pharmacological manipulation that you can do. Now, an opioid rotation is different opioid, but the same route. Okay. For example, orally you're giving morphine, but you're changing it to methadone orally. Now, what are the indications for opioid rotation? One is when there is intolerable side effects of administering oral morphine, which is neurotoxicity, or if there's poor analgesia despite titration of the drug. Now, how does it work? This works on the principle of incomplete cross tolerance. That means both are acting on the same receptor, but that opioid receptor is receptive to the other opioid that you're giving. As a result, you can have increased analgesic efficacy as well as decreased side effects. So when you're converting morphine to methadone, it is acting on the same receptor, but because of that incomplete cross tolerance, it is being effective as an analgesic, whereas morphine was not effective. So you have greater than anticipated potency with the other drug. That is how opioid rotation works in difficult cancer. Next, please. So there are 3 steps when you're converting one opioid to another. The first is you must look up the equianalgesic table to find out what is the equianalgesic dose of the other opioid. Or in other words, what is the oral morphine equivalent, or OME. For example, 25 mics per hour fentanyl is equivalent to 60 mg morphine. So when you're converting from morphine to fentanyl and you're giving 60 mg morphine, then the equianalgesic dose is 25 mics per hour. But there's another thing that you need to know is once you calculate the equianalgesic dose, because there is some amount of cross tolerance, you need to reduce that dose when you're giving the new dose, new drug like fentanyl. For example, if the pain was well controlled, then you have to reduce it by 50%. Or if the poorly controlled pain, then you have to reduce it by only 25%. Okay. And then do not forget to prescribe a rescue dose as well. So this is a step for opioid rotation. Next, please. Now, opioid-induced neurotoxicity, how does it manifest? That is one of the reasons why you're doing a rotation, right? So you need to know what is the features of opioid-induced neurotoxicity. So this could manifest as sedation, over-sedation, delirium, myoclonus, hallucinations, hyperalgesia, and seizures. And the cause of it is the metabolite of morphine, which is a morphine 3-glucuronide, and also normeperidine. So these are the metabolites, which are toxic metabolites, which are accounting for the neurotoxicity. Next, please. Now, I mentioned about opioid rotation. So in step 3, we have only 2 opioids that can be used in place of morphine, that is methadone and fentanyl. Okay, in India, we have only these 2. Methadone is very inexpensive as compared to oral fentanyl patch, and it can be given orally. But remember, they are all under the same legal control as morphine. Next, please. So use of methadone for difficult pain. I don't know whether I should mention it because it might have been already dealt with in step 3 opioids, but just briefly going through it, the advantages of methadone are its high potency. It is also effective for neuropathic pain because it acts on the NMDA receptors as well as it is a serotonin norepinephrine receptor inhibitor. So this is the advantage it has over the morphine. Secondly, another advantage is it has no active known metabolites. It has a long half-life, unlike morphine, of 8 to 12 hours. It can reduce the risk of breakthrough pain because of its long half-life. It does not accumulate and in renal impairment, again, unlike morphine. Less tendency for tolerance and no cross tolerance, and low cost. Okay, these are some of the advantages of methadone. But the main disadvantage is there is a risk of life-threatening ventricular arrhythmias if QTC is prolonged on the ECG of the patient, which is torsades de pontis, which is a very life-threatening kind of an arrhythmia, ventricular arrhythmia. And also titration is difficult and there's a risk of overdose as its half-life is unpredictable. And also very important, it should be given only by experienced palliative care doctors. Next, please. So when you're doing the indications for methadone in difficult pain are, first of all, as an opioid rotation, as an opioid switch, you can use methadone. It is very inexpensive. It can be given when there is true morphine allergy, when you can't give morphine, and in neuropathic pain. Remember, I told you that it is very effective in neuropathic pain. But the contraindications, if there's a QTC prolongation, when there's no reliable caregiver, when there's history of sudden unexplained death in the family, and also when there's a drug interaction. So patients on azithromycin, amitriptyline, and fluconazole may not be given methadone. Next, please. Okay. When you're converting to morphine to methadone, this is the way you go about it. Now, 60 mg morphine orally, if you're giving, then that is equivalent to 2 to 7.5 mg methadone. But if you're giving more than 60 to up to 199 oral morphine equivalent, or the patient is less than 65 years of age, the conversion factor is 10:1. That means if you're giving 10 mg morphine, then you give 1 mg methadone. But if you're giving more than 200 mg morphine, then the conversion is 20:1. That is 20 mg morphine to 1 mg methadone. So it is available as 5 mg tablets and syrup as 5 mg per ml. Next, please. Now, as per the expert consensus white paper, the equi-analgesic dose for methadone are very conservative, and we need not account for incomplete cross tolerance. So we do not need to reduce the dose by 25 or 50%, like I mentioned for earlier. So that is usually done for fentanyl only. Next, please. Now, the other strong opioid we have is transdermal buprenorphine. It is available as Buvelot patches, 2.5 mics per hour or 5 mics per hour. It is a good option for opioid rotation, better pain relief, good tolerability, can control neuropathic pain and breakthrough pain better, and it usually lasts for 7 days. Next, please. So having done that, again, we have to review the cause of pain to see whether is it a nociceptive pain, neuropathic pain, or is it a mixed pain? And do we need to give adjuvant drugs? Having discussed morphine, now we are coming to the adjuvant drugs. Okay, next, please. Now, I mentioned this earlier also in my earlier slide, that nociceptive pain is due to tissue injury and neuropathic pain is because of injury in the peripheral nerves or in the central nervous system. So we have to see whether that element is also there, and accordingly we can add a drug for neuropathy. Next, please. So this again I had alluded to in my previous talk about the neuropathic pain ladder. So I won't go through it again. Next, please. And again, this also, the commonly used neuropathic drugs are anticonvulsants, antidepressants. Step 3, like I told you, methadone, very effective. And even step 2 drugs like tramadol and tapentadol, because they act on the descending pain pathway. That is, it is a serotonin norepinephrine receptor inhibitor. Next, please. Now, ketamine, it acts for neuropathic pain because it acts at the NMDA receptor, which is present in the substantia gelatinosa in the dorsal horn of the spinal cord. And that is how it is used for difficult to treat neuropathic pain. Next, please. So we all know that ketamine is an anesthetic, but it is an analgesic at sub-anesthetic doses. So we can give oral ketamine in dose of 10 to 25 mg TDS, or you can give subcutaneous or intravenous ketamine in a maximum dose of 100 to 200 mg per day as an infusion. Or we can give what is called a burst ketamine or a pulse dose of ketamine. In that, what you do is you have to admit the patient and monitor the patient and start a syringe pump with 100 mg per 24 hours of ketamine and give it for 3 days. If it is not effective, then you step it up to 300 mg in 24 hours for 3 days. And if that is not effective, then you go up to 500 mg in 24 hours. And if that is not effective, then you have to stop ketamine. So this is what is called a burst ketamine dose, and it is useful for refractory pain. Next, please. So even oral ketamine can be given in the home setting, but in chronic regional pain syndrome, at least it is not very effective in complex pain. Next, please. But there are side effects of ketamine. You're aware that it can cause dysphoria, hallucinations, nausea, vomiting, dizziness. So you can prevent these psychotomimetic side effects by giving haloperidol or a benzodiazepine like clonazepam or midazolam. Next, please. Now, ketamine can cause hepatotoxicity. And this has been observed in patients with chronic regional pain who were treated with ketamine. So we need to closely monitor the liver function as well, particularly with prolonged or repeated ketamine infusion. Next, please. Ketamine can be abused. It has been used for recreational purposes also. And in such patients, you can develop a vesicopathy or lower urinary tract symptoms. but this usually resolves after cessation of the therapy. That is not very commonly seen in India, but abroad, maybe people do use it as for recreational purposes. Next, please. Now, local anesthetics for difficult neuropathic pain. Now, unlike the anticonvulsants, which is blocking the calcium influx into the presynaptic neuron, local anesthetics acts at the level of the sodium channels and decreases the neuronal excitability. So it is very useful in neuropathic pain, but it has a potential for serious toxicity. And so it is reserved as a second line treatment for severe intractable crescendo type of neuropathic pain. Next, please. How do we give it? It is given as an IV local anesthetic infusion. Remember, we have to use the Xylocard and not xylocaine because Xylocard does not have the preservative in it. That is methylparaben that can cause the neurotoxicity. So you have to use Xylocard in a dose of 5 mg per kg as an infusion over 1 hour. And you can repeat it maybe 2 or 3 times over the next few days. But you have to monitor for the side effects, the central nervous system and the cardiac side effect. So monitoring is to be done and the patient is to be kept in the daycare. It's also available as topical local anesthetic patches, which is called Lidovelar is a trade name. It's a 5% lidocaine patch. It's now available in India. You can apply up to 3 patches per day. But just remember, it has to be put for 12 hours and the next 12 hours you have to remove the patch. Otherwise, you can land up with toxicity. Next, please. Now, cannabinoids in difficult cancer pain. We all know that this has been used from ancient times to treat various ailments. But in medicine, this use has been restricted because of legal and social concerns, and also because of abuse and misuse of the drug. But there are few symptoms in cancer pain which may not respond to a routine palliative care methods. And there is a place of this agent in those cases. There is no robust clinical data, but the anecdotal reports are there, and it is yet not included as a routinely included in palliative care treatment. But based on anecdotal evidence, there is a place of this in certain situations. Next, please. Now, these endocannabinoids act on the CB1 and CB2 receptors in the central nervous system. And the CB1 receptor accounts for the well-known psychomimetic effects of cannabinoids. The 2 phytocannabinoids that have been extensively studied are THC, which is tetrahydrocannabinol, and CBD, which is cannabidiol. Now, nabiximol or Sativix is an oromucosal spray containing a 1:1 combination of THC and CBD. THC, remember, is a principal psychoactive constituent of the cannabis plant, and CBD has got anti-inflammatory properties. This has been shown to be well tolerated with improved analgesia in opioid unresponsive cancer patients. Okay. Next, please. So what are the uses of cannabinoids in palliative care? It is good in neuropathic pain as a step 3 or step 4 line of treatment, not as a first line treatment. And a subset of patients can benefit from prolonged cannabinoid. It can be given as an oral oromucosal nabiximol or inhaled herbal cannabis or nabilon and dronabinol. I'm not even familiar with the drug, so I'm not even sure of it. Okay, then it can also be used to treat chemotherapy-induced nausea, vomiting. This is difficult to treat sometimes. Cannabinoid receptors are present in the emetic reflex pathway in the brain. And the drug used are, again, dronebilon and nabilon. It's used in cancer anorexia also, in HIV-related cachexia, in multiple sclerosis-associated spasticity, and its neuropsychiatric effects help in improving the general well-being and quality of life in patients with chronic illness. So these are the uses of cannabinoids. I've taken this from a recent review article in IAPC written by Sushma Bhatnagar and her team. Next, please. But it has adverse effects like drowsiness, somnolence, dry mouth, GI side effects, and psychoactive effects, and of course, the potential for addiction. Next, please. In India, abroad, it has been regularized in certain countries, particularly for pain of multiple sclerosis and refractory pain and cancer. But in India, what is the status? What is the legal status? There was a petition in the Delhi High Court which challenged the provisions of the NDPS Act and said that it should be legalized for medicinal purposes. And this is still in the court. And they have said, the court has been told by the center that we can use cannabinoids for medicinal and scientific use, and it is not completely banned for this particular use. Next, please. Now, corticosteroids in neuropathic pain, for bone pain, for headache due to raised ICP, or for arthralgia. So these are all the adjuvants that, like multi-purpose adjuvants that you can giving to treat difficult pain. Okay. Next, please. GABA agonists like baclofen has been used for treating pain associated with spasticity. Next. Bone pain, again, very difficult to treat pain, important cause of refractory pain, and it can be very agonizing. What they cause is called skeletal related events. So we need to treat that pain. And how do we do it? Next, please. We can give corticosteroids and NSAIDs. Calcitonin, recent reviews have shown that it has no effect on significantly improving the quality of life. But the drugs that are commonly used are bisphosphonates and denosumab, and they act by inhibiting the osteoclast-mediated bone resorption and reducing the skeletal-related events. And of course, that's palliative radiation. Next, please. So the drugs that we are using is the bisphosphonates as a zoledronic acid. It is more cost-effective than denosumab. It is given as an IV infusion every 1 month. You have to give 4 milligrams IV. There is more risk of renal toxicity and less risk of hypocalcemia. Whereas denosumab is more expensive. It's given subcutaneous in a dose of 120 mg every 4 weeks. But there's less risk of renal toxicity, but you have to monitor the calcium levels, and we may have to give calcium and vitamin D. It is superior as compared to bisphosphonates in delaying the skeletal-related events. And it has also got a better median survival rate. Next, please. Then palliative radiation also can be used to treat bone pain, and it usually takes a few weeks for effect, but it can be quite useful in such patients. Next, please. Next. Then pain due to bowel obstruction can be treated using steroids. You can use a somatostatin analog like octreotide or anticholinergic drugs, or you can give a combination of all three for bowel obstruction. Next, please. So having discussed a pharmacological option, we come to the non-pharmacological options for difficult pain. Next, please. So the non-pharmacological options, the first one I will talk about is the invasive interventions for cancer pain. They include nerve blocks, epidurals, patient-controlled analgesia, neurolytic blocks, or intrathecal pumps or spinal cord stimulation. So they are reserved for those patients with intractable pain who are not responding to the step 3 drugs. Next, please. The other non-pharmacological therapy include dry needling, acupuncture, biofeedback, psychological therapy, physical modalities, spiritual therapy, and alternate therapy. Next, please. So physical therapy can be very effective in patients as a multimodal approach, multi-pronged therapy. Along with your other treatment, you can add physical therapy. It will be found to be quite effective. You can apply heat, cold, tense. You can teach how to do their activities and also exercise to maintain the functional range of motion. Next, please. Now, many of patients with cancer have got psychosocial and spiritual issues, and fear, anxiety, depression, anger, guilt, financial issues, fear of the future, concern about loved ones, loss of role or role reversal and questioning God. These are all the psycho-spiritual issues that can be present in patients with terminal cancer. And you can treat it with counseling, communication, medications, support groups like art, music therapy, dance therapy, or even financial support. Next, please. Now, coming back to our case, let us review the cause of pain in this particular patient. Next. Now, there could be medical reasons for his increase of pain. This could be either because of progression of disease, because the colostomy site definitely looked unhealthy, or could it be a failed route of absorption? Was it poor oral absorption of opioids, or was there a decreased transdermal fentanyl absorption? Because remember, he was on fentanyl patch also. Or were there other psychosocial concerns in this gentleman? Next, please. Anyway, what was done? We had to admit him to the hospital. A colostomy was found to be non-functional in this particular patient. So that was obviously the cause of severe pain. Possibly there was a progression of the disease because he had a colon cancer. So a root conversion was done. He was started on fentanyl infusion with supportive care in the hospital. The pain subsided. End of life care was instituted, and this was explained to his relatives, and he expired free of pain 2 weeks later. So that was how this gentleman was treated. Next, please. So in this particular patient, where we too drug-centered or intervention-centered in our approach, we need to review the non-pharmacological interventions as well. Now, what were the psychosocial concerns of this patient? He was a highly educated retired doctor. He had no financial concerns because his entire medical treatment was covered. He had a supportive family, a caring wife and a daughter. His main caregiver was his wife, and she had taken over the role of the head of the family, managing all the medical and the financial affairs of the patient. Next, please. So what were the psychosocial concerns of this person? He was depressed because he knew, being an educated person, he knew that there was no cure and that he would not live long. So he had a sense of hopelessness, helplessness, and powerlessness. He could not do anything about his condition. He had psychosocial concerns. He was experiencing loneliness and isolation. He had withdrawn from friends and relatives for the last 2 years. And his only people were his wife and his children and an occasional doctor who would come and look at him. He had a low self-esteem because he was totally dependent on his wife, even for his self-care activities, like colostomy care. He had developed a fissure in ano, so he had to be given a sitz bath. So there were so many issues that his wife was taken. So he had a very low self-esteem. He also had a sense of guilt because his family had given up all their activities. She had given up her job so that she could be his full-time caregiver. And there was a role reversal because his wife had taken over all his responsibilities. Next, please. So if you look at this slide, it's a little not very clear, but what I want to tell you is that this is the step 1 and step 2 and step 3. But in step 4, you may have to go for the various pain interventions. Okay, like I said, epidural, intrathecal pumps, or maybe a neurolytic block, but also the psychospiritual issues need to be addressed. That has to be addressed at every step of the ladder. And of course, there are advanced interventions like cordotomy, cingulotomy, tracheotomy. But remember that these advanced neurosurgical interventions, the risk-benefit ratio is not very good, and the risks will far outweigh the benefits. So these are generally not undertaken even for treatment of intractable pain. Next, please. But sometimes, despite our best, everything can fail. So in such cases, you may think of palliative sedation. But we can accept failure, but we should never desert the patient. We should always tell them that we are there with you and we offer whatever kind of support we can. We have to be frank about our failure to relieve pain, but we can convey that with sensitivity. And we have to continue the psycho-socio-spiritual support and treat any worsening of the patient's condition. Thank you.
Thank you, ma'am. As you all know, it's a very important topic also, dealing with difficult pain. Yes, Dr. Anuba, please go ahead.
Ma'am, I wanted to ask you about what is the success rate of spinal cord stimulators in such patients who have difficult pain, specifically in India? Um,
Are you talking of cancer pain or non-cancer pain?
Non-cancer pain. I have come across a few cases, and particularly a female who was dealing with neuropathic pain, CRPS, and she was put on a spinal cord stimulator, but ended up having a semi paralysis, like hemiparalysis for after 6 to 8 months, and her spinal cord stimulator was removed. So, and I've come across a similar case.
What was the cause of the paralysis? Is it because of the stimulator or because of the underlying condition?
Ma'am, what we were told was that the stimulator was removed actually because of the reason. And she was able to, after physiotherapy and occupational therapy, she was able to move after a year. So,
See, spinal cord stimulation, as far as I know, for cancer pain, it may not be that effective, but it is used many times for patients who have got spinal degenerative disease with severe neuropathic pain. Okay, like for pain that is not responding to your pain interventions. So in such situations, secondary to spine degenerative disease, you can use spinal cord stimulator, but it's prohibitive cost and the maintenance of it, for which you're totally dependent upon the manufacturer. Even the doctors will not be able to do it. The manufacturer has to come for all the any problem in between, any malfunction, or even adjusting the current, everything you're dependent on the thing. So people are doing it. I myself have only once been involved in this, using it for patients with I think it was a failed back surgery syndrome or something like that. But otherwise, I don't have much experience with it. But like I said, the prohibitive cost and the high maintenance dependence on other people for its maintenance. So I think in very, very selective cases only it can be used, where you have support also of the company person who can regularly come and do all this.
Thank you very much, ma'am. As you mentioned, it is used very less in India. This is the reason when we come across such cases in our organization, we also don't have answers. And then I also came across an article where it was mentioned that Caucasians have a better result with spinal cord stimulators than Asian. So there was a difference that I came across. So I just wanted to know if you could highlight something more there.
Here we are. I mean, there are certain doctors who are putting it in. Many surgeons are doing it also. But like I said,
Ma'am, yeah. Ma'am, we can't hear you.
Ma'am, you're not audible.
hello?
Yes, ma'am.
Yes,
Now
yes.
yes,
Now you're audible.
Do first a trial by inserting the temporary leads, and then you have to, after that only you will know whether it's effective, and then only you should do the final implantation. So abroad it is being used more often. But in India, there are few centers that are doing it, but I don't think it will be very effective for cancer.
No, ma'am, the patient was not having cancer pain. Her diagnosis was complex regional pain syndrome, and with a history of 8 years of dealing with the condition.
Okay.
Yes, ma'am.
It is chronic regional pain syndrome, is it?
Yes, ma'am. Complex regional pain syndrome. Yes, ma'am. And with a history of 8 years of pain, being CRPS type 2, it was a nerve-induced nerve compression that led to it, met with an accident. So,
where is this person?
Ma'am, Noida.
Actually, in Noida, is it?
Yes, ma'am. She got us some pain specialist in Noida only did her treatment. We came across her when she had gone into a paralysis state. So for us to provide her support and take it further was difficult because we were also not able to understand where to help her out here. So, but it was a 1 year long journey, and now she's doing better. She can walk and everything. But she's had some progress. But and we came across another case like that only, and she was a 19 or 20-year-old female. So I mean, this was the two cases that we came across.
Which institution in Noida?
Ma'am, I am not aware of the center. I'm sorry, I'm not remember right now. We got the case in our organization, Chronic Pain India. So it was mostly when something severe has happened, and or something doesn't work. It's like those kind of cases reach us. So doing a history back and not proper check sometimes get difficult, and especially I mean, getting every detail from the patient sometimes get difficult.
Any other questions?
Ma'am, one question is there in the chat about role of transcranial electricals and magnetic stimulation.
I have no idea whether that can really help. I know that it can. It is mentioned in as one of the therapies for intractable pain, but I have no personal experience. I'm sorry.
Dr. Satyajit, please go ahead.
Thank you. Ma'am, good evening. This is Dr. Satyajit. And at the outset, I would like to thank you for such an eloquent talk. It was so soothing to hear you. And I mean, having a, it's like even if you have pain, it'll be a wonderful experience just hearing your talk. It just felt like that. So I had a question to ask you that is regarding the use of steroids for, say, bone pain due to skeletal mets or something like that. So what steroid do you start and what is the dose? And suppose the patient has his pain controlled with steroids. Do you then consider tapering the steroids over a period of time, or do you consider giving it even if the pain is controlled?
This is for bone pain you're talking
about?
Yeah,
bone pain, ma'am.
Okay. So normally the steroid that I use, now I have my personal preference, is dexamethasone, because it has got less mineralocorticoid activities and it has got a long half-life. Its half-life is up to 36 hours, right? So you can give a once-a-day dose. And the dose that we would give, see, I don't know, I mean, we give it not for, like in a dose of 8 milligram per kg body weight, you can give it, but usually we give it only for a week and not longer than that. Once-a-day dose. And this is my preferred drug. Even for intracranial metastasis, I would also use the same thing. If the intracranial mets, then again, dexamethasone is good, mainly because of its lack of, at least not so much of mineralocorticoid effects. So,
Ma'am, you said, sorry to interrupt you. You said 8 milligram per kg or 8 milligram?
Milligram total dose.
Total dose, yeah. So when you consider it for intracranial mets, what are you looking at? Because these patients need not be necessarily having pain due to an intracranial mets.
Yes, intracranial mets, when the patient has it, there is what is called a peritumoral edema that happens. And because of that, the ICP rises, right? So most commonly, if you look at the MRI, you can make out the peritumoral edema also, the edema is shown in the MRI. And in such patients, it is very effective because it is very effective for reducing the peritumoral edema. And that is how it can reduce the intracranial pressure. There is what is called an intracranial compliance curve, what is called the pressure volume curve, right? So brain, follows a Monroe-Kelly doctrine. That means it is such a rigid structure that, the buffering capacity is only through the spinal canal. There is no other buffering capacity in the brain. So at some point of time, even a small increase in pressure volume can cause a large increase in pressure. So, and that could be because already the compensation has taken place at the spinal, the CSF has already moved down, and now there is no more compensation, and then any slight increase in the volume can cause high pressure and pain. And it may be just an edema, and if it's edema, definitely it will respond to dexamethasone.
Thank you so much, ma'am.
Thank you, ma'am. There is a question from Dr. Shweta. Is the line of treatment and the drugs or routes are same for intractable pain in children as well?
See, I don't have much experience with children, frankly speaking, but I'm not sure whether methadone can be given in children. Maybe Sridevi, you should be able to take that call. But in adults, I mean, in children, definitely oral to intravenous can be done. But I'm not sure about the use of either patches or methadone in children. I have no experience. Will you be able to enlighten on that?
Yeah, I don't. We have had children in pain where we have used opioids, but never used something like ketamine or lignocaine or even methadone. Yes, but the child was kind of. I mean, he was 15, 16, but other than that, like we have not used anything other than that.
I
And then
know
some,
that ketamine can be safely given as an anesthesiologist. I've given ketamine in children. They're well tolerated in children for anesthesia. But for pain management, I suppose you can give it for intractable pain. Morphine and fentanyl can be safely given. Intravenously, fentanyl can be given. And morphine, I think, can be given orally.
Yes.
But beyond that, I will not be.
Even morphine, fentanyl, I have used all the routes, IV, subcut, oral, everything, but not the others. Yes, Dr. Shweta, please.
ma'am, how about the adjuvants then? Those will, like, for example, for neuropathic pain, especially. Does that also differ, or that can be as per? Like,
Children,
yes, yes, yes.
again, I have no experience with Lyrica in children. And I don't even know what is a per kg body weight dose.
I
Because in
read,
adult, we know it is 75 mg starting dose. But there
I,
must be a per kg body weight dose, but I have absolutely no experience with children.
I came across an article, ma'am, wherein obviously the amitriptyline and that TCA group and all was ruled out, but they have started with gabapentin. I'm not entirely sure if it's the right dose, but it said about 30 milligrams or something. Oh, sorry, 5 milligram per kg per day of pregabalin. I'm not sure of that. So that is what.
Excellent question. And I think it's a food for thought for all of us. I myself will do my homework on this.
Yeah, I think me too. Dr. Shweta, it will be great if you can send these questions to me. So we
Yes.
have another team, like Dr. Gayatri and team working in Hyderabad. They have extensive pediatric palliative care services. So we'll get in touch with them and get back to you with. We have children in with palliative care needs, but most of them have non-cancer issues. So I'll definitely, like, it's like ma'am said, it's a food for thought for us too, especially for adjuvants. Yeah. So just send those questions to me. I'll get back to the entire group with the answers.
And
Will do.
Sridevi, there's last time someone raised an issue about the tapentadol. Is it a step 3 drug? So it is a step 3 drug. It has been, people have told that it needs to be upgraded as a step 3 drug because it is very potent drug as compared to tramadol. It is like 50 mg tapentadol is equal to 15 mg morphine. So there is a recommendation that it should be included as a strong opioid. So that is something I came across. Someone had raised that question last time. Remember?
Yes, yes, I remember. I know that there was a recommendation, but I was not sure about whether they have actually included in step 3, because in whatever step 3, I think it's not, I mean, kind of included as a step 3, but on regarding its action, it is definitely about
Potency
tramadol.
wise,
Yes,
potency, it is almost like a step 3.
yes. From what age can you give Silocard in patients with persistent pain?
Persistent pain, intractable pain, right?
Yeah, I think that's what Dr. Anubha meant.
Okay. See, Xylocard, the dose is clear. It is 1.5 milligram per kg body weight. Okay. That is, there we know what it's in kg body weight. But as an infusion, again, I don't know whether there are any, it's been used in small children, but definitely over the age of 15 upwards, when they can almost like an adult, you can use it. Okay. But below that, I'm not very sure, but we give Xylocard in a dose of 1.5 milligram per kg in anesthesia. But I'm not sure about for pain.
Any other questions? Yes, Dr. Shweta.
Sorry, ma'am. I don't know if this is a silly question, but is there any drug or to reduce the toxins or the metabolites, like any detox regimen that might be useful?
You mean the neurotoxicity of morphine for that?
Uh, accumulated toxins, accumulated metabolites that you were talking of. Is there any?
I think the only thing you have to do is reduce the dose. I think, I don't know whether Sri Devi will be able to add to that.
No, that's why I said maybe a silly question. I'm not sure if it is possible.
Sri Devi, say anything. I can only know that when this happens, you have to reduce the dose. That's something.
Yeah, and make sure the output is normal.
Yes.
I think, yeah.
I think this time they're asking tough questions, no, Sri Devi?
This is
They are stumping
you're
us.
giving us homeworks to do, to go back and read and come back. But thank you so much for that. We will definitely pediatric. We wanted to add to this session, but then it's like you can't finish it in one session. Everything needs a separate session. So that's why we did include that in this particular program. Yes, Dr. Shweta.
No, I just ask these questions, ma'am, because we these non-cancer cases, wherein even cases of cerebral palsy and a lot of neurological conditions, wherein it does not respond to any of the pain medication or any alternative therapies. So that was the reason why I wanted to get some idea. But I'll also read about it and I'll forward the articles, whichever I can find for this.
But one thing about cerebral palsy, okay, is the pain in cerebral palsy due to spasticity or is it any other reason? And if it is
yes, ma'am.
If it is spasticity, then you can give either a baclofen orally or you can do dry needling for the spastic muscles. Okay, you can also think of non-pharmacological options. Everything is not pharmacological. So you can give Botox therapy, you can do dry needling to treat the spasticity-induced pain, along with maybe a drug like baclofen or lioresal.
Yeah, I share the same thought. We had one boy referred to us. He was around 20 plus 30 years of age, continuously crying in severe pain for years. And it was just pain from the spasm. And I started baclofen and he had neuropathic pain also. He was very clearly telling that needle prick sensation and amitriptyline. It just worked like wonder. He stopped crying and he was even the mother felt it so easy to take care of him because there was so much of spasm she was unable to manage while dressing him up and bathing. But the pain has completely disappeared. He stopped crying the whole day and night. So I share the same. Ma'am, there is a question from Dr. Ariba. What drug should be given to a patient with CA colon with colostomy who has continuous feeling of tenesmus? No drug in step 1 and 2 are effective. Knowing morphine can cause constipation and fentanyl patches are expensive for them. So how should we manage the tenesmus? I think Dr. Ariba is telling step 1, 2 is not enough. Step 3, she is worried about constipation.
Yes. And the patient can't afford also the fentanyl patches because we were thinking of fentanyl patch, but the patient can't afford it. So for morphine to start, me, I thought maybe it will cause constipation and there would be like problem related to the large intestines also. So what should we do in this matter?
My setting, we still use morphine, and we manage the bowel according to the patient's comfort because we don't have enough drugs in step 3 to experiment. Even with tramadol, it can cause constipation. Tapentadol again can cause. Even with fentanyl, some people, it's not like 100% not constipating drug also. So in our setting, we definitely tell the patient that this is a drug which can so we have to make sure that we give proper attention to managing the bowel but giving proper pain relief with morphine. That's what we do here. Dr. Ariba, you're muted.
Ma'am, do we prescribe them with laxatives? for bowel management, or do we prescribe them something else? Because I have come across with the patients who have these symptoms after like they have been through this colostomy thing, because they are having this feeling of tenesmus all the time. They feel like they should defecate, but they're not, because obviously they have been operated, and they say that we also pass some kind of fluid when we have this urge of defecation. So what should we do at that time? Because I have come across like 2 3 patients who were having the same thing, so I couldn't prescribe the morphine because of this thing, because I thought maybe it will increase their feeling of tenesmus
So I have a
will the
patient now.
laxatives work? Yeah, sorry.
Ma'am, we can hear you, ma'am.
Hello, can you hear me?
Yeah, now we can hear.
Yeah.
Now we can.
Also, I have a patient who has a colostomy, but who has a malignant melanoma in the rectum. And that patient also has passing fluid all the time, through the rectum. So he has to put diapers over there, or constantly he has to do. So this is a problem, we can't control that. But I don't think morphine is contraindicated in that case. You can give
Okay.
morphine. In fact,
Okay.
this patient is on fentanyl patch, quite a high dose of fentanyl patch.
Yes, I agree to the same. We can give morphine. I don't think it will actually aggravate the existing tenesmus. I have not seen that. It may not actually aggravate the tenesmus, but maybe over a period of time, he can practice some colostomy irrigation and stuff that will slightly help at a later stage. I think
Okay.
that's it.
Okay.
Shall we start the case presentation and then take few more questions? Dr. Biswas?
Yes, ma'am.
You can start.
Good evening, ma'am. I'm Dr. Bishwas, anesthesiologist, NIMS Medicity. Next slide, please. Oh, this patient is a 32-year-old female patient. The diagnosis is aggressive hemangioma involving the C7 and T1 vertebral bodies. So the presenting complaints is pain right side of the neck radiating to the right hand, 2 weeks duration. History, the patient had an insidious onset of pain right side of neck radiating to the hand, 2 weeks duration. Initially, the pain lasted for 20 to 30 minutes and later it became continuous. The intensity of pain was more during the daytime. There was also numbness of the right little finger, and there was no associated muscle weakness. There are no relieving or aggravating factors. On the examination, the pulse rate was 78 per minute, BP was 120/70, temperature was normal, and the cardiovascular and respiratory systems are normal. The movements of neck are normal. The muscle power is grade 4 on both arm and forearm, and there is loss of sensation on the lateral side of little finger. Investigation hemoglobin was 12.7, RBS was 110 milligram per person, sodium, potassium were normal, X-ray test was normal. In the MRI of the cervical spine, there was a lightly destructive and slightly expansile bony neoplasm involving the C7 and T1 vertebral bodies, encroaching on the right lateral recess and foramina with nerve root compression. The diagnosis was aggressive or atypical vertebral hemangioma. And the treatment, this patient is planned for surgery. Now, meanwhile, the patient is on pregabalin 150 milligram BD, duloxetine 30 milligram OD, and methylprednisolone 16 milligram OD. The previous slide. This next slide. And she's a staff nurse, and she's the main earning member of the family. She has a 1-year-old breastfeeding baby born after treatment for infertility. And her husband is a painter. She has no medical insurance, and the surgery involves huge expense. So main concerns are she is getting breakthrough pain, and the guarded prognosis after a major surgery, huge medical expense, and a dependent child. So summary, this is a 32-year-old female patient presenting with history of pain right side of neck, radiating to the right hand, and the MRI showed a neoplasia involving C7 and T1 vertebral bodies, possibly an aggressive hemangioma. She is planned for surgery. She is on tablet pregabalin 150 mg BD, tab duloxetine 30 mg OD, and tab methylprednisolone 60 mg OD. And she is getting breakthrough pain. So discussion point, this surgery is planned for 1 month later because the center she is planning surgery has a long waiting list. So she's given date in May. We are trying to prepone it. Then she is getting breakthrough pain. So should the drugs be changed or increased? And also this middle class family, she is a staff nurse. So there is a financial problem also. Thank you.
Thank you, Dr. Biswas. I think there are a few chats coming up. Yeah, so Dr. Ariba is telling. Dr. Ariba, this was for the tenesmus, right? You have mentioned, or for this case presentation? Sorry.
No, ma'am, case presentation,
Yeah,
ma'am.
okay, because there was a continuation from the previous
Sorry,
chat. So I was just, no,
sorry,
no,
sorry.
it's okay. So yes, drugs should be changed because pain is organic. Pregabalin and duloxetine works for neuropathic pain. Dr. Ariba, would you like to just talk about it? You are muted. You are muted.
Yes, ma'am. Ma'am, basically, duloxetine and pregabalin both work for neuropathic pain or the psychological pain. Since this pain is due to like she's having hemangioma, and there is also like we have seen in the MRI some C7 and T1 involved. So I think she like this patient should be reviewed again, and the drugs should be changed to like the drug that will relieve the bone pain. Maybe she's having the bone pain. And
Thank you, Dr. Ariba. Thank you so much. Yes. Thank you. That's very valuable input. Any other comments? I understand there are people working with pain in this group. So we'll look for some comments from your side.
Sri Devi, can I
Yes,
just
ma'am.
come in?
Sure, ma'am. Yes, yes.
Riba, the lesion isn't C7 T1 vertebra, but it will be causing a nerve root pain also. Okay. There is a bone involvement. There could be bone pain, but in this particular person, because the pain is going down the arm, it is because of a radiculopathy. Okay. It's a nerve root pain. And we need to give these particular drugs for nerve root pain because that's a neuropathic pain.
okay, sorry.
So duloxetine is a SNRI, serotonin norepinephrine receptor inhibitor, and pregabalin is an anticonvulsant. So you're combining step 1 and step 2 drugs to treat the neuropathic pain. So I think that is perfectly legitimate, right? At this stage, you don't need something to treat bone pain because the pain is going down the arm, just a neuropathic pain because of the nerve root involvement. Okay, that is what I just want to clarify about that.
Okay, ma'am.
Justified in giving this drug.
Anyone else?
In fact, the radiculopathy is along the C7 nerve root, And that is going up to the little finger, which means it is a C7 nerve that is involved. Okay, so we have to also see how the pain is radiating also. Depending on the radiation, you will be able to tell which nerve root is involved. Okay.
Can we consider adding some opioids like morphine, because the pain is still not controlled with the use of these drugs? So is it
I have not seen any step 2 drugs being given in this patient. See, tramadol can be given because that can also be effective for neuropathic pain. So only when we rule out tramadol, we need to go to morphine, right? In fact, tramadol has an added advantage to morphine because it can be used to treat, along with opioid receptors, also inhibiting neuropathic pain as well because of the serotonin and norepinephrine receptor inhibitor. So I think we should give a full dose of tramadol before we go on to morphine. And I think that should be added to the treatment regime, a tramadol with paracetamol.
Okay.
I just wanted to, it would have been nice to listen something about the pain scores that makes things a little bit easier and clearer to decide on which drugs, whether to escalate the existing drug. What is the response in terms of pain score to the current medication? Has it come down to 7 from 10, or has it come down to 6 from 10? So I think that's the most important point that I like, because I don't get an idea about how intense it is. So when Dr. Satyajit asked about opioids, then I thought, okay, that's why I skipped to the slides again, because then I don't know what is the intensity, whether it is moderate pain or severe pain. So it's, I think that's one important point that we can all start practicing.
And the other thing we also need to know is, are there any features of neuropathic pain? Okay, now that we know that's a neuropathic pain, is there tingling? Is there numbness? Is there hyperalgesia, allodynia, electric current-like sensation? These things also should be asked. So you need to elicit whether that patient has got, it's besides intensity, you need to also check about the features of neuropathic pain, is it there or not? You've given the right treatment, agreed, but that need to be there in the case discussion.
She has only numbness on the right little finger.
Oh, she has now. That's good. So that means there is a feature of neuropathic pain.
Right.
Ma'am, would you like to comment on the medications and how to go ahead with the treatment of pain till she gets the definite management after a month or so?
I think we should give a full, I mean, analgesics also should be added to this regime. Otherwise, steroid is good, pregabalin, duloxetine are good, but we need to add analgesic as well. So you can add a paracetamol tramadol combination in this patient. And only if it is not getting, and then you can go up to the proper doses, you know, up to 300 to 400 mg of tramadol. And if that is not working, then only, I mean, then we can escalate to morphine. But this is it a malignancy? Or it's just a hemangioma, right? It's not even a malignancy, no, Dr. Bishwas?
We have an MRI diagnosis now. We have no histological diagnosis, only definitely surgery, and after pathological examination, we can definitely see.
Yeah.
Now it is such a, it's a benign tumor.
It's a benign tumor. Hemangioma is benign tumor. So, I mean, be cautious about starting morphine in this patient. So I think we should give a full dose of tramadol with paracetamol and then take it from there. And then maybe we can add a little sedative at night if the patient is not sleeping well at night. We need to address the other issues as well, the psychosocial issues that can also contribute to pain. So we need to see whether the patient is sleeping well, and if the insomnia is there, then you have to give her some sedative at night. So these adjuvants also need to be added.
I just wanted to raise a point because Dr. Biswas said that she has a baby who's being breastfed, if I'm not mistaken.
Oh, yes.
So all these drugs that we are giving, would that not have some effect on the breast milk secretion and on the baby as well?
I don't think it is recommended in lactation.
Yes, tramadol definitely not.
So, you know, worst comes to worst, she'll have to stop lactation. In such situations, you may have to go on to feed the baby other way, because after all, she cannot tolerate this kind. We have to give her the medication. So we may have to discontinue lactation and give her top feeds.
So these would be other important aspects of counseling. And
very good point you raised, that she's not
Yes, yes.
and so the medications also have to be given. She's on so many medications, so it's advisable not to give it for lactation.
There are a few more questions again. Can we give, breakthrough dose of tramadol or tapentadol and then gradually increase the pregabalin? And there is a question on how long can we give steroid? When can it be tapered and stopped?
Pregabalin, she's already getting a high, good dose. And I don't think she's her body weight may not be too much. I think this 150 mg twice daily is quite a decent dose of pregabalin. Maybe you could increase the duloxetine, but I think this is good enough. Steroid, I think we should give it only not too long. I think 5 to 7 days, and then we have to taper it off. You can't give it indefinitely, the steroid. Whatever edema there is, it will reduce in that time. And moreover, methylprednisolone has a long action. It can last up to 3 months. I'm not sure, but I think it has a very long acting effect. So I think it's not more than a week you should give methylprednisolone.
Ma'am, there's a question, can we use cervical epidural steroid?
See, the problem with cervical epidural steroid, unless you're giving a root block. See, if you're giving cervical epidural, you're not sure where the drug is going, right? You're going to inject it in the epidural space. It can go anywhere. You may not be targeting along into the particular nerve root. You understand? The particular nerve root involved is C7. How can I be sure that whatever drug I'm giving is going to that area? Because at that area, there is a blockage. And when there's a blockage, the drug will go elsewhere. It will not go, it will go to the place of least resistance, right? So when you're giving an epidural, the problem with epidural is that you're not able to target any particular route. Ideally, you should give a selective nerve block, selective root block. Okay, like you can give like a transforaminal or a nerve root injection. That can be given. But again, when you're giving steroids like methylprednisolone, because it's a particulate steroid, there is a risk of thrombosis. If it gets intravascular, it can occlude and you can get ischemia. So you have to be very careful. You have to use a non-particulate steroid like dexamethasone when you're giving a nerve root injection. Epidural, like I said, we can give it, but it will be acting all over the place. It may not exactly go to that particular nerve. Selective nerve root is better, but then you can't give a particulate steroid like methylprednisolone, triamcinolone. You have to give a non-particulate steroid like dexamethasone. That could be effective if you give a selective. Ideally, this lady should have surgery as early as possible so that that nerve compression is removed.
Any other question? I missed any other question? Yeah, I think Dr. Dheeraj, I think you got your answer about escalating the pregabalin dose. Madam already touched upon that. And I think very good point Dr. Satyajit mentioned about the breastfeeding, and it needs a lot of counseling because they had baby after the treatment and then they may want to, she really have to choose between the pain relief and probably the breastfeeding. So that takes some time to come to that conclusion. That's a very, very valid point which we actually missed. Are there any other questions based on this, or? So maybe if there are no other questions, maybe we can wind up today's session. And Dr. Shweta, please send in your questions that you asked. We'll get back to you. Thank you so much, everyone, for the wonderful interactions and I think I enjoy these interactions more because we all learn a lot when you ask questions and then share your thoughts. That's a great feeling after the session, after each session, I must say. So thank you so much for being interactive. Thank you so much, ma'am, for answering all the questions with patience and sharing your experience in such a nice way as always. Thank you so much for being with us.
Thank you so much.